This week on the BackTable podcast.
Yeah, and I think too an issue is like when I started at this job, I did all my follow-ups. But as you get busier, it is hard to do your cases and your consults. And so primarily the nurses and the MAs do the follow-ups. Now, I do instruct them if somebody's not better. Like my whole algorithm is if they're not better at 1 month, then do a 3-month follow-up. Because there are people who, aren't better at 1 month still. Like it takes 3 months that we see for, it could take up to 3 months for a lot of these people. And then if they're not better, then it's a follow-up with me. So am I losing some of these people? Am I not knowing about some of these people? Because honestly, I don't hear a lot back from the staff. Like, of course I do. Maybe it is like 10% of the time, let's say. Gestalt, just trying to, because I don't really actually crunch the numbers. But how accurate is that? I don't know. If they're really capturing these patients, or they're like, oh, you're not better, peace. Okay, cool. Have a nice day. I don't really know if that's happening or not.
All right. Welcome to BackTable, everybody. Thank you for listening. I've got 2 great guests here today, and we're here to talk about GAE and kind of the where we are with GAE these days. We're going to cover a bunch of ground here, I think, but I've got to start. If you know me, I'm Don Garbett. I'm sometime guest host on the BackTable, but I've got Rachel. Why don't you say your last name for me so I don't screw it up?
I say it wrong too sometimes. It's Piechowiak.
I would have definitely screwed that up. And then Faraz.
You got it, Faraz Khan.
All right. And Rachel and Faraz are both at IR centers. But let's do a quick intro for each of you guys. Rachel, why don't you go first? Just tell us where you're from, where you trained, and how you got to where you are now.
So originally from Buffalo, New York. I did my medical training in New York, my fellowship training at Mount Sinai. I ended up meeting Sunny Bagla at a conference, and there was like a job opening down in Virginia. I was looking for something different and ended up down here, and he kind of became like my mentor. And then now at IR centers and doing embolizations all the time, and it's really great.
And did you start, was that your first job with Sunny, or were you?
Oh no, I was in practice. So after training, I had a job in Long Island that was like hopping around a bunch of hospitals and stuff. It wasn't really a great job. And then I worked at a hospital called South Nassau in Long Island, and I was there for about 3 years or so. So I had about 5 years under my belt, but I wasn't professionally satisfied. I was doing a lot of diagnostic, and I was just not really doing a lot of really great cases. I did launch a Y90 program, but it wasn't really, very high volume. And so I was setting out, going to these conferences, like willing to move anywhere pretty much along the East Coast to look for something better. And so I really lucked out.
So IRDR private practice, it sounded like?
The 2 prior jobs were hospital-based private practice that were combined IR, DR. And the last job that I had before I moved down here was a ton of call, like every other week. And I had to cover both diagnostic and IR call. So it was pretty rough. I mean, the call itself wasn't very like high volume, but as you can imagine, it's a little bit of a burnout factor.
Yeah. So kind of the traditional route. And then you moved into the outpatient space with Sunny, and then IR centers from there. And then what city are you in now practicing?
Reston, Virginia.
Okay, excellent. And then you are primarily focused on musculoskeletal embolization, right?
I'm primarily focused actually on prostatic artery embolization. It was very heavy MSK before Faraz, or actually before there was a doctor before that came on board. And then I go to the Leesburg office 1 day a week, and that's where I do all my MSK stuff. And then I have some, at the Reston office, but Faraz definitely is the heavy ortho guy.
Okay. All right. So thank you, Rachel, for introing. And then Faraz, same thing. Where you're from, where you trained, and then, how you ended up in the position you're in now and what you're doing.
Yeah, so similar to Rachel, I'm also from upstate New York, born and raised in Rochester, so not too far from Buffalo. And I stayed in New York pretty much up until now, did all my training up there, undergrad and medical school. and then did my integrated IR residency up in Albany. So I finished that up, and this was actually my first job right out of training, and joined the group right out of training. So a little different from Rachel, but it's been a great transition coming from the hospital and being in the OBL space.
Yeah, great. Well, I think you need a few years of overnight call.
Yeah. And then you could circle back with us.
There we go.
Yeah, then we'll talk. Well, awesome. So, and then Faraz, you're doing a lot of musculoskeletal embolization, as I understand at this point, correct?
Yeah, primarily doing a lot of the MSK embolizations at our center. And then Rachel and I will kind of flip-flop, and I'll do some of the GU PAs as well. So we'll kind of be able to get a lot of experience on both sides.
Okay, excellent. All right, so that's great. Good intros on where everybody's from and what your practices are now. So I think for the, tackling the topics as we go through GAE, we'll just kind of go back and forth. As far as, workup, patient workup, how is your practice as far as how you work up the patients with knee pain for GAE? Are they coming in, fresh with not much information? Are they coming in with a lot of information already? Is it a mix of both? And then do you do any testing after that point? And I guess let's start with Rachel for the workup part, and then we can bounce back.
The vast majority of our patients actually come from an ortho group that is affiliated with, it's like a multidisciplinary practice type of a thing, but the Leesburg office is associated with this ortho group. So most of them come from there. But we're also running 2 clinical studies. And so there's a lot of patients that also come through Facebook ads. And then there's word of mouth patients who had friends that have been treated that come by, or even just patients that are desperate and are Googling, they tried everything else. They really don't want a knee replacement. And they just find us because we do enough of it. So, we're probably like higher up on that search engine.
Most of the patients are seen by ortho ahead of time, and so the workup's probably already mostly done.
Yeah, so most of the time they have at least x-rays that are commented on. We know that they've had injections or not, how long they've worked. So we do get a good amount of information ahead of time, but for the ones that are just coming in fresh, they're well aware usually of what their situation is too. And so personally, unless it's in the setting of the clinical study, I don't really order a whole lot of extra MRIs. If these people are known for a long time that they have arthritis and they've tried, X, Y, and Z, and they're just trying to avoid a knee replacement or delay a knee replacement.
Yeah. And then Faraz, similar thoughts? Any other thoughts?
Yeah, very similar, kind of a little bit of a mix, primarily a lot of referrals from the orthopedic surgery group, and then self-referral patients as well. It's a good amount, and family members or, just kind of by word of mouth has definitely been increasing over the time, which is great. But for the most part, yeah, they have a good workup with the orthopedics guys, and so they'll at least have some plain films for us to refer to. Some of them will have an MRI, so that'll be helpful as well to see if they have some of the findings, synovitis, for example, but not everyone does. I don't, like Rachel, I don't routinely get an MRI for every single patient. If it's there, it's very helpful, of course, but not something that I require for patients.
Yeah, I think I've kind of followed the same camp. When in my previous practice in Oregon, we had a very large ortho group that we worked with. And I think for the most part, they all had x-rays. Some of them had MRs. And the stories almost always matched up. Like, this is ongoing pain. I've had joint injections. But I would have a rare patient who, I think I had a sports coach for a university. And he started having like really intense knee pain out of nowhere. And he was in his 70s, but no knee pain prior. I was like, let's just do an MR. This seems weird, even though you're 70, with no knee pain and then sudden knee pain. And he had a fracture. It was interesting. So we just, I sent him back to ortho.
It's easy to kind of fall into a trap too, because like you see it time and time again. It's almost like you're predicting people's stories. And so it is good that you point out that it is like a red flag to look into if it's sudden onset, because we know this works, for a lot of people. And so it's kind of, in my personal opinion, I'm like, well, let's try it. If you tried everything else and you don't want a knee replacement, let's see, and so, but obviously a case like that is not a good idea.
Yeah, I think the chronic scenario, I think, fits very well with GAE. I think the only thing that threw me was you have sudden knee pain.
Yeah.
And when I saw him, I was like, oh, I'm sure this is chronic, right? And you've had this for 6 months. He's like, no, it just started 2 months ago. Never had knee pain before. I was like, oh, okay. He was a track coach.
Yeah, I think from that standpoint, like history is definitely important. So I always like to try to just have them walk me through their kind of journey with knee pain, how long it's been going on for, just so I kind of can tease those types of things out and make sure there isn't any sort of red flag. But for the most part, it's kind of the run of the mill. It's been going on forever. It's kind of more medial pain, or I've tried this and that, physical therapy, over the counters, injections, and nothing's really been helpful. I don't want to get a knee replacement, and here we are, type of a thing. So kind of helps get their side of the story.
How about when you talk to them beforehand, doing your consultation, what do you tell patients? What's like your dialogue as far as here's what you can expect, and here's what we're going to do, and here's what we can expect out of your symptoms?
Yeah, so I'll just kind of be very honest with them and not guarantee perfection at all. Obviously, I really just kind of try to set up their expectations appropriately, that this isn't magic. I'm not going to be able to take you from a 9 or a 10 out of 10 pain down to a 0. If it works, that's great and amazing, of course. But, I try to just kind of temper their expectations a little bit, that this will, help you in terms of the pain, maybe to the point where you're not having to use over-the-counter medications or narcotics as much. You're able to kind of do a little bit more in terms of your activities of daily living. But I try not to kind of set them up with too high of expectations where they're going to feel like, well, I thought this was going to cure my knee. I was going to be, doing amazing type of a thing. But I do have those results. That's amazing, of course. But I like to at least kind of undersell a little bit and kind of see how they do.
Yeah. Under promise, over deliver.
There you go.
That's a good one. Yeah. So I usually describe it to people after they walk me through their story as, I kind of describe this as the last stop before getting a knee replacement, or for people that don't want to, or they can't, have tried everything else. Some people haven't tried everything else, but they already know that injections are short-lived and don't really even want to go down that road. So I'll usually explain it to them like that. And I also tell them we're not restoring anything. We're not, your knee joint destruction is there. We're not restoring cartilage. We're not doing any of that. We're just focusing on the inflammation and the associated pain, and hopefully, helping you gain function. And I do tell some patients we are sometimes maybe just kicking the can down the road. Some people ultimately need a knee replacement anyway, but there's people who say, I'm a teacher and I just need to get through the summertime, or I just need to get, through my son's wedding or something like that. And so I think when you shape the expectations appropriately, almost everybody is on board, to be like, yeah, I think this is worth a shot. And it's not a promise, and sometimes I'll reference our prior studies that the average person might have a 50 to 60% reduction in their pain score and similar improvement in their function. And I always mention about, obesity or carrying really any excess weight, or the grade 4s, that they just might not have the same durability. Because I get a lot of questions about durability, and I don't have a really good answer, because I usually also tell them the key is avoiding misuse and overuse, because that's kind of what got you there in the first place. And so it might not be a very satisfying answer for some patients, but it's really hard to say, depending on who it is.
Yeah, especially if it's a weight, which I think a lot of the folks that we see end up being obesity related, just because the joint replacement is not a great option for those folks. And so they end up getting kind of this as an option. What do you think as far as, durability? Do you give people time, references for time of, how long is this going to work? Do you tell anybody anything?
I don't, because I still don't have my brain wrapped around it very well. And so I give anecdotal, stories that we have patients from when we worked in Woodbridge who years later are finding our partner, like me or my partner, to say, okay, this knee worked great, and now I want to, I'm still doing good, and now I want to treat the other knee. I'll reference Dr. Okino, in his Japanese population, where he's done MRIs on these patients years later, and for the ones that it worked for have no further joint destruction. So I kind of extrapolate what I know, and then kind of put it back on them, especially for the overweight patients. Like, weight loss is critical. If you have this undue strain that's altering your biomechanics. We can fix this now, but it's going to happen again down the road if you don't fix the actual problem. So I do not give a time frame. I wish I had a better. Do you guys, I don't know, what do you guys do?
Do you for us?
I will. Sometimes I'll kind of like tell them, in terms of the available literature, maybe like 1.5 to 2 years or so. But with the big caveat being that, for example, for a large population with obesity, if you're not addressing that issue, it's probably going to be less time just because you have that extra weight that's putting more burden on that joint. So things like that are certainly something that I'll give with nuance and try to make it specific for the patients.
I think that's a good caveat to give folks. I think for the most part, when I first started doing it, I think, we had Okuno's data, and I would reference that, in some data sets, we see about 2 years of pain relief, but we might see pain recur before that. I've had some, and then anecdotal, I've had some patients who are good 5 years out, and then others who have pain coming back at 6 months.
Those ones are frustrating. The ones who do great and they're already back, because it's like, yeah, we can redo it, but I don't know how many times. How many times do we do? We can't do it every 6 months indefinitely either, so. Yeah,
it's not a steroid injection.
Yeah, right.
Okay, so we could talk about, I think, I was going to talk about who to treat and not to treat, but I think we should hit that maybe at the end and talk about our procedure approaches. So you've got the patient who's got chronic knee pain and the story sounds good, and you're bringing them in for their procedure. Maybe let's flip it, because we've been starting with Rachel a bunch of times. Let's start with Faraz. How do you decide your access site? How do you decide your whole procedure plan? Why do you go through your logic and how you approach?
Yeah. I think for the most part, as I kind of joined the group, it was pretty pedal heavy in terms of getting access and doing GAs for that, which I had zero experience with in training. So I was a little nervous about starting that, but great support and mentorship always helped. And now I'm pretty comfortable doing it. So for the most part, I'll try primarily pedal if possible, but I'll always do a pretty thorough vascular exam just to really make sure that they're a good candidate. So really taking a look at their arteries with ultrasound, making sure there's no big calcifications, look at the waveforms in particular, and make sure that, things look appropriate for us to do retrograde pedal access. And if there is any sort of issue, femoral. And I'll always, for my patients, prep both the groins as well as the foot, just in case type of a thing. If I'm running into issues or I just can't get a wire to go through, I'm not going to, muddle around too much. I'll just switch to femoral access and do the procedure that way. But for the most part, if I can do pedal, I'll try to do pedal.
Okay, and then let's flip to access for Rachel as well. What do you think?
So I had a ton of pedal access experience in my last job with doing a lot of arterial work, and so those people were usually like about to lose a foot. So there was it wasn't scary because it was nothing to lose. You know what I mean? And so, but that was helpful for me to when we started doing GAE, especially in the clinical trial situation, we had to go groin. That was what the FDA mandated, right? So it was nice when we started doing this off study to have that opportunity. And it was a slow, because the last thing you want to do is trash a healthy foot. That's a totally different scenario. But so I do pedal 99% of the time. I actually treated my friend's mom, and I went into both of her pedals and they were somehow she didn't even have evidence of vascular disease. And of course it was my friend's mom. And so I had to convert to groin, but I will always do pedal. It's just, if I can, obviously. And I always check the waveforms as well. But even if they're blunted, I still try pedal first, because I'm like, well, if they have vascular disease, I'd rather just deal with however many centimeters and up and over and potentially iliac disease and all this other stuff. So it's really my go-to. I will start that way 100% of the time, unless for some reason if it's under 2 millimeters, then I won't. So I did have to do that once or twice, but it's just so much, in my opinion, so much better for the patient. They're only laying, recovering for 45 minutes to an hour. They don't have to lay flat that whole time, and they don't have to deal with the puncture site care afterwards. But it is a scary leap for people who don't do pedal. But I remember when Faraz started, he had done tons of radial, and I was like, I think it's easier than radial, in my opinion.
Yeah, now having the experience, I would agree.
Yeah.
So when you're examining the ankle, are there things that, if you look at it, you're like, I'm just not going to do that without checking waveforms?
I'll at least take a look with the ultrasound. I mean, if I get a good palpable pulse, that's obviously great. But, if it's a little difficult for me to palpate, I'll still, slap the ultrasound probe on and take a look. Try to just kind of run it up and down, the DP, AT, PT to see what's going on. So for the most part, our team's pretty well set in our routine of, patient will come in and they'll have the ultrasound waiting for me. So I'll be able to kind of make that determination. And for the most part, they kind of know at this point that we mostly go pedal anyway, so they'll kind of set up our tables like that. But on occasion, I'll let them know, this is a femoral case, and they'll get things going that way.
And I also prep the groin and the foot just in case, there's an issue.
Yeah. If I see like one of the vessels that's a bit smaller, one tip I learned from Ivy, who's another one of our colleagues that does a lot of MSK embolization. So she puts a little bit of nitro paste on top of, either the DP or PT beforehand, just plump it up a little bit. And I've noticed that certainly helps a little bit during getting access. So I've been doing that a bit more ahead of time, and it certainly helps a little bit.
What do you think about PT versus AT? Does it matter to you guys?
Most of the time I end up doing the DP. I like having that bone there because I feel like I often just end up going through and through unintentionally. And so that bone is kind of like, it seems easier. PT, I struggle with PT for a couple reasons. I feel like as soon as I'm turned 90, I feel like dyslexia sets in as soon as I'm putting the probe and I'm like, what? And I'm flipping the probe and I'm flipping the probe and I'm like, I don't know, that doesn't seem right. And so unless it's a big beefy artery that's close to the surface, I actually usually prefer the DP, but I just did a case today and I want PT because it was nice and big and like just underneath the skin. And then one other thing about DP is that it's easy access to the anterior tibial recurrent because it's like a straight shot versus if you're coming PT, it can sometimes be more challenging from there.
Yeah, for that angle.
Yeah, I'd agree. For the most part, I'll try sticking the DP as much as possible, but if it's a nice big juicy PT, I'll go for it. And some of the older folks, I feel like the PT can certainly be a little bit more tortuous as well. And so that can kind of give me a little bit of difficulty in terms of getting a good spot to hit and not having any issues with the wire.
Yeah, there's always seems to be that little jog that can happen right around the malleolus area. And so sometimes I try to go a few centimeters distal to that, or sometimes I try to go above because sometimes your wire gets caught up there.
Just to avoid that little turn one way or the other. I think I started doing them in like 2017 or something. And I remember initially, I didn't have a lot of info and I was just doing up and over. And I remember it would take a while. It would take like an hour and a half because I was fighting iliacs and doing all these things. Yeah. I mean, I'd probably do it faster now, but the speed increase when I started going antegrade fem versus up and over was like half the time. And then when I started doing pedal, it was kind of about the same speed. So I have that sensation or that feeling that the torqueability is just so much better. So you can move your micro so much easier and your base cath so much easier.
It reminds me of doing a radial PAE when you have to do a femoral up and over GAE. It's just so far away and hard to control.
The translation of your moves is a lot different.
Mm-hmm.
Okay, so how about, let's go through a GAE and just give me, okay, I get access. Where do I shoot my first pictures? Do I use AP? Do I do angles? Let's start back to you, Faraz. Let's do that.
Sure. Yeah, I'll get access with a slender sheath, administer our pedal cocktail, and then I like to, my usual base catheter is like a 5 French Navigate 3 catheter and I'll use that kind of as my primary catheter. So I'll kind of backload it with a glide wire and then kind of like insert it into like the little valve at the sheath and kind of under fluoro advance it. In the past, I've done like a little run via my sheath just to take a look and see how the runoff looks. And I'll certainly do that if I see if there's any calcifications or if a patient does have some vascular disease. But for the most part, if the glide wire is going okay, I'll try to just kind of get up into the pop and do my first run there.
So sort of the blind move up, as long as everything's moving smoothly.
As long as it's safe and going okay. If I'm having any issues, I'm obviously going to go and do a run.
Yeah. And then where do you do your first, like, do you go mid, do you go to the pop and shoot? Do you go higher in the SFA and shoot? Where do you take your first picture?
Yeah, if I can go, into like the distal SFA, just like I usually kind of angulate the C-arm a little bit, usually about either 25 to 30 degrees, and kind of right where where we're crossing over at the hiatus, I'll try to just get the base catheter right there and try to do a good run.
So kind of at the hiatus. And then you're angling 20. Which way are you going on the angle?
Depending on if I'll go LAO for a left knee and kind of get at 30 degrees there to do my runs.
So kind of ipsilateral angle on the leg. Okay. Rachel, access approach, and then it's kind of same strategy, or do you do something different?
It's very similar. I do angiograms on all the legs before I go up, just because the glide picks off everything. So I find that if I don't, I'm always getting stuck on something. So I'll do that. Also, just to see if there's anything I have to do, like if I have to give heparin or something. Maybe there's a stenosis, that I wasn't aware that I was going to see. So I might. Well, I always give a cocktail, so that happens regardless, the heparin. And then I was starting. Up until recently, I was actually starting with a burn, and I found that invariably, I could usually get into 2 or 3, but I always switched to something else. So because you're coming from the foot, the angles, coming from above versus coming from below, obviously you're having different issues with different arteries in the knee, and so what I've just recently moved to is starting actually with a Hastings U. I don't know if you guys are familiar. Well, you are obviously, Faraz, but
I remember you talking about this catheter, yeah.
And I love it because as long as you're not pulling down on it, it's very atraumatic. So you can put it in, and as you push it up, it's gonna make this kind of a thing. So as long as you're pushing it up, it's never gonna, unless there's some calcification that can be an issue, but you're not dragging it against the vessel, and it automatically makes a reverse curve, where with the nav and the TCB&K, it is a little bit of effort to try to make that reverse curve. And so the reverse curve I use always to get into the medial inferior, which I think sometimes can be the most challenging artery. And so I've started with that because I know I'm going to use it for at least one every single time. And then if I have to switch out, I'll switch out. Like today, I used that. I used the TCB&K because it was accidentally opened. I used the NAV 3 as well. And actually, it was the first time in a long time that I had to bail on getting into the medial inferior, which was frustrating. But yeah, so I start with a Hastings U now, and I with the other curved ones, it made me nervous, and particularly in women, about the dragging and potentially causing spasm or potentially dissection or something. I don't have that same. I'm not nervous about that with the Hastings. Up until this point, I haven't had an issue, with that. So
I think I'm familiar with the catheters, but I think just for listeners, I think everybody knows a burn or a Cumpy, and then a NAV 3 is almost like a short right angle, almost like a very short turn, straight at 90 degrees. And then the Hastings is almost like, I think a lot of people would call it a mini Omni or a mini rim almost, but longer, right? Like a tiny sauce that fits in the femoral, right?
And stable too. Like you're not going to lose your loop. Like if you're trying to make a loop with the other ones, sometimes it flips up when you don't want it to and stuff. This is the only time you're going to flip it back up is if you're putting a glide wire, all the way past it.
So the microcatheter won't flip it. Microcatheter won't flip it back out.
I haven't had that problem. Yeah. That's what I like about it. But it could be annoying sometimes. It has its pluses and minuses.
I was going to say, one of the good things I feel like of the Hastings is it's a bit longer. It's not just that 65 centimeters, so it's a little bit longer in case you have a taller patient as well. Run into that a little bit if I'm using like a shorter base length than taller folks.
With the DGA,
sometimes I just have to swap it out. Yeah, that D, sometimes I have to just swap out.
Yeah, I think that's always the challenge if they're a little taller. So the Navigate and burns are like 65. I mean, you can get a longer burn, but the Navigate's 65, and then the Hastings comes like 80 or something?
90.
Oh, it's 90.
Yeah.
So that gives you a lot more flexibility. That's nice. So same though, do you angle your II relative to the knee as well?
Yeah,
or do you stay P? Or?
It's always an ipsilateral oblique, but I never really pay attention to the number. I'm honestly just looking for the patella in the middle and, and making sure that it's a true AP view. So whatever, because a lot of times their feet start out one way and they start flopping out, as the case goes by. So I try to tell them to just be as comfortable as possible before I shoot that. And then I'll adjust it, that way. And I'll start there. And then if I have to make adjustments, if I'm having trouble seeing the origins of some of them, I tend to go closer back to center than more oblique when I'm trying to look for other artery, origins and stuff. I feel like I do that most frequently. And I start similarly to Faraz at like Hunter's Canal or a little bit above where the SFA starts to straighten out, because I have a recurring problem sometimes of shooting too low and then I can't see the DGA and then I have to do it again. So I feel like you have to get a few steps. Yeah. I mean, there's a lot of variability of the origin, but they can come up pretty high.
Okay. So then in your cases, how many arteries are you targeting? Are you only targeting things that are hyperemic on your base run, or are you assessing each one? What are you doing? What's your strategy? Start with Rachel.
I always ask them ahead of time their pain, where it is. And I do find, unfortunately, more frequently than not, they're not just medial pain. They're not just lateral pain. I feel like a lot of them can't identify it exactly, or they're saying it's the whole knee. And even if it is just medial pain, I probably on average, I probably target on average about 5 arteries. So if they have laterality to it, I usually just start from the top and work my way down. But if I know it's exclusively medial, I'll go down all the medial ones. If I'm having trouble with one of those, instead of getting frustrated, I'll go for, I'll start looking on the lateral side. Particularly what I found, I don't know if you guys have a similar experience, but the inferior lateral tends to very often have an anastomosis with the medial side. So if somebody has medial pain, I might not look at all the lateral arteries, but I will usually always check the inferior lateral. 1, it's usually easy to get into, and 2, I often see some kind of cross-filling situation to the medial side. So yeah, probably about at least 3 to 5 when they have global pain. Sometimes all 6.
Yeah, I'd agree. Pretty similar to Rachel. Definitely minimum of 3. Try to just get if they have medial pain, get the medium column arteries. When I first started, I was just kind of focusing on that. If they had medial pain, I would just treat the medial arteries. And if they had lateral, I'd go for the lateral. But similar, if you really tease out and kind of work with their physical exam to try to see where they have that palpable pain, it can be, sometimes just really very medial, but a lot of the times it will be both medial and lateral. So started just looking at some of the other arteries as well. And similar to Rachel, I saw that there was sometimes a lot of cross communication. And I would agree with that inferior lateral. It definitely wraps around and brings a lot of flow sometimes. So I've been routinely just kind of checking them all. And if there is either synovitis that I see with hyperemia, or if they're crossing over to the medial side, then, I'll proceed with treatment.
And another thing that might happen is I might incidentally get in an artery on a side that's not bothering them. And then they have a ton of inflammation. And so I'm like, that's weird but I treat it because it's there. And I think about the masking situation, like in people who have arterial disease, right? They don't even really realize their other leg's hurting until you treat the leg that's hurting worse, and then it unmasks. And so I don't know if that's also going on with some of these knee patients, where I had a patient the other day and I was getting into these arteries, and sometimes I ask them, does it normally hurt here? Yes or no. And this one particular patient was like, yeah. He's like, it actually does hurt here. He's like, I didn't realize how much it hurts here, but yeah, this is one of my spots. And so because it's so hard, I think sometimes for patients to really localize it, getting into investigating them, if you have the time in your schedule and you're not getting bogged down with the difficult origins and stuff, it's worth exploring for sure.
Yeah, I think I've gone the same way. When I first started doing it, the logic was figure out where the pain is, hit that artery, be done. And then I think as you probably feel the same way, as you get more efficient at getting into these arteries, it's like, okay, I'm going to check 5 arteries probably, and anything that's kind of hypervascular, we're going to treat. And as someone who has knee pain, I know that on one day, one part hurts, and on another day, another part hurts. If it depends if I'm walking stairs or if I'm running or if I'm carrying my daughter around, what kind of pain I have today versus tomorrow.
So when are you getting your GAE? Are you going to do it yourself?
Oh man, I'm coming to one of you guys for sure. I had a hard time for like 2 weeks, just really intense pain. I was like, oh no, I need a joint replacement, but it got better. Okay, so we touched on how you access, kind of procedural technique, catheters that we use. How about microcatheters? I think, are you using straight ones or curved ones, 2.4, 2.1, 2.0? What are you using?
Yeah, I'm using a 2.4 straight ProGrate, 130 length usually.
Yeah, I'm doing the same.
Have you tried the angled ones here and there?
Maybe a long time ago. I might have once or twice, but I haven't found them to be very helpful in this situation. Well, how about you? Do you?
When I first started doing it, I was just using burn cath, and then the angled, the swan neck tip microcatheter became helpful because then I had a burn angle and then the swan on top. So it was like two burns on top of each other. But now that I'm using better base catheters than the burn, you don't really need it. I haven't found I need them.
You have to use a 1.9 French. In one of our studies, they were wanted us to have them on the shelf. And I was like, okay, but I never used that, but okay. And that week I had a study patient, and I needed it because I couldn't get in with the 2.4. So yeah, it was just really, really
wired it and the catheter wouldn't go.
Mm-hmm.
So then you downsized. Okay.
Yeah.
Interesting.
But that's very rare. That's usually a 2.4.
One time, sounds like.
It was one time. Yeah.
Okay. Yeah, that's about right. Anybody using cone beam for GAE? Thoughts on cone beam for GAE?
We don't have that kind of technology.
Yeah. Yeah. I've thought about it back when I first started doing them, and I was just like, how would I even use this for a knee?
Are people doing that for GAE?
There are people doing that.
Okay.
I think, it's academic. I think folks are getting 3D images and writing papers on it.
Okay.
I think it could probably be helpful, if you don't have a lot of experience with them. Just I feel like it is a little difficult if you do your first angiogram to try to pick out some of these genicular arteries. And then, if you're not very well versed with them, it can be a bit confusing which ones are genicular versus soleal branches. So I could see the utility of using cone beam to try to really, verify that you're in a safe target spot to treat. But I feel if you have their mentorship or, someone that really can teach you how to pick up these arteries and get facile at them, that it's not necessary 100% of the time.
I guess I feel the same way. I don't, if we had someone on who felt very strongly about it, I don't know how I would talk about it. I was in a mixed cath lab for years, and I would see these guys just catheterizing coronaries all day, no cone beam. They're just they would grab the C-arm and just kind of pull it and push it while they're injecting, and then, they would kind of smush it in very gently, I should say. But I feel like it's similar. And I remember watching Okuno put some live cases up years ago. I don't know what catheters he was using, but I saw where he was just, slowly injecting. He was puffing his way into these vessels. And when I saw that, I was like, oh, wow, you can really, find the origin by kind of puffing your way in. And, as long as you're conserving contrast, which if you're using these tools, it seems very easy. Okay, so we've discussed tools and those things. Embolic. So there's beads, there's liquids, people are using the Piechowiak, there's temporary embolics. What do you guys use? What have you used in the past? And what do you use now?
I can go first. I've pretty much exclusively used imipenem for my cases. So a good resorbable agent. It's kind of just how I was trained to use it initially first. I've done additional cases with microspheres as well, but for the most part, I'm using imipenem for pretty much every case.
And then size-wise, are you using the case to decide if you're using particles?
Yeah, if I'm using particles, it certainly depends, if they have hemarthrosis or if this is just, OA that I'm trying to treat. But for the most part, about 200.
Okay. Rachel?
Yeah, so started off doing this back in 2016. And so in the beginning, I was using mostly, the first trial was 100 micron particles. Then we went up to 200 micron particles for a long time, resorbable optospheres at some point. So yeah, I was doing 200 micron primarily particles. And then about last summer made that transition to imipenem, and it's almost exclusively imipenem. It's just so nice. It's forgiving. You don't have to worry about, I mean, the beads, there's a nuance to the beads. When you're familiar with using the beads, it's really not scary, you know, but still you got to make sure you're not overloading the catheter and pay attention to those nuances. But I really do like the imipenem, and it seems there's still, I don't think there's any evidence to show that beads are superior to imipenem. They seem equivocal, at least to this point. I don't know if something new has come out that I'm not sure of, but to have it be equivocal results and not have to worry about the potential for non-target and things like that, I think it's a very user-friendly embolic.
Yeah, I think we've got data to support all these things, right? We've got data for different bead sizes, different brands, we've got a ton of data on resorbable now with imipenem. And then we've got people using Lipiodol as well, which there's data to support that now. On the personal side with data, I don't know that it matters what we use, as long as we're decreasing blood flow in some manner to these areas. And then I do have a very brief, I was doing a adverse event. I was doing a GAE years ago on someone who was quite obese, and the ankle was not going to work. And so I went radial, which you probably know is a mistake.
I think you told me about this before.
Yeah. And I'm using a 175 microcatheter and just barely made it into the medial genicular. And I didn't account for how much length was in the catheter. And I was embolizing my first vessel, and I didn't want to pull the whole thing out. So I kind of cleared it. And by the end of clearing it, I could see it. I could see the contrast going through the vessel and back into the pop and then running down. And she ended up having a whole lot of toe pain for almost a month. And I had to put her, so I took someone to knee pain and gave her toe pain instead. And I had to put her on oxy for probably about a month.
But no like skin breakdown or anything like that?
Zero.
Okay.
No ulcers, no petechial things in the toes, nothing.
Oh,
it was
wow.
just pain.
Okay.
Yeah. And that was I think it was with 100 to 300 beads at the time. It must have been, yeah. In general, I guess, do you quote patients so there's technical success, clinical success, do you quote them, our technical success rate at completing, being able to do this procedure for you is around what? 90%, 100% related to we find an occlusion and we can't treat you or something like that.
Yeah, I usually say about 90 to 95% in terms of technical success. There's always going to be those outliers where either there's blockages or, something that's going to limit me in terms of what I can do. But for the most part, that's usually what I'll quote them.
Okay. And then Rachel, same with technical success?
Yeah, I usually quote the same, over 90%. But for clinical success, I kind of fall back on the nuance thing about the grade and the obesity. I don't really like coming up with a number for that.
I think that's hard. I was sat in a journal club, an orthopedic journal club, and we were talking about GAE because they just wanted to know about it. And we were talking about joint replacement. And I think the paper about post joint replacement GAE had just come out. I forget who wrote that one, but it had just come out. And so they wanted to hear about it. So we were talking about it. And one of the guys is like, I never have patients with pain after joint replacement. And a whole bunch of the other orthos just started laughing. Okay, you're the only one, buddy.
Because he's done
I
4
thought that was
at
funny.
that point. Really.
Yes. Yeah, probably. But we're in our own little world, and everybody in every field knows you do a procedure, it doesn't necessarily mean they're going to get the expected outcome. Whether it's a spinal fusion or a joint replacement or a GAE.
Yeah. And I think too, an issue is when I started at this job, I did all my follow-ups. But as you get busier, it is hard to do your cases and your consults. And so primarily the nurses and the MAs do the follow-ups. Now, I do instruct them if somebody's not better. My whole algorithm is if they're not better at 1 month, then do a 3-month follow-up. Because there are people who, aren't better at 1 month still. It takes 3 months that we see it could take up to 3 months for a lot of these people. And then if they're not better, then it's a follow-up with me. So am I losing some of these people? Am I not knowing about some of these people? Because honestly, I don't hear a lot back from the staff. Like, of course I do. Maybe it is like 10% of the time, let's say. Gestalt, just trying to, because I don't really actually crunch the numbers. But how accurate is that? I don't know. If they're really capturing these patients, or they're like, oh, you're not better, peace. Okay, cool. Have a nice day. I don't really know if that's happening or not.
Yeah, that's a good point. So follow-up is a tricky thing, especially once you get busier. I know, in the when I was doing a lot of vascular disease, like every patient was coming in every 3 months, right? So you have automatic follow-up. But in this pain world, it's like, okay, we'll have you follow up in a month. How are you doing? You're doing great. Okay, excellent. But it's only 3 months. Like, what if you have pain coming back 3 more months?
And if they have pain that comes back, do they say, all right, I'm just going to get a knee replacement, and we never even hear about it?
Yeah. I think that's a little tricky.
The long term's hard, and even the clinical studies aren't going out. One of the ones we're doing now is going out for 2 years. So that's not even really long term.
I know. I've looked out. I went through all the data. We had our journal club on GAE a while ago, and I went through all the studies, and I was like, no, there's no study that goes 5 years. Not one.
And that's what the insurance companies argue to not cover it.
Yeah. Why don't we have a study going out 5 years? Follow-up is hard for anything. But I think it would be nice if someone would publish a 5-year data study. Even Okuno doesn't have a 5-year study. I was very surprised. But yeah, I follow the same as you, Rachel. I do the 1 month with the staff generally, unless it's like someone who specifically wants to follow up with me about it. And then I instruct them that if they're not improved, same goes for anything else we do. If they're not improved in 1 month, follow up with me at 3, and then we'll go from there, kind of in that strategy. Same for us, same idea for you?
Yeah, very similar. So I did my own follow-ups at the beginning just because I wanted to see how the patients were doing, and I wasn't as clinically busy. So I had that time to really just kind of follow up on my own. So that helped at the 1 month mark, just to kind of see how they're doing and kind of tease out maybe some information. I think that helped me a little bit as well in terms of critiquing my own skills, in terms of going back and looking at my runs and seeing, what exactly I did and, did that help or not, type of a thing. But as I've gotten busier, it's definitely shifted towards the staff doing a lot of the follow-ups, but I'll use the same approach in terms of a 1 month. And then if there isn't improvement, I'll try to do a 2 month as well, just to kind of check in with them. I'll do that personally. And then I'll try to have them do another one at 3 months if possible. And then one thing we've been doing is just kind of having them routinely follow up with their orthopedic provider as well, or whoever's kind of helping them out, just to make sure that they're in the loop as well, to make sure that they're not just forgotten about.
Yeah, I think it's probably a good closed loop. I think if you get the, Facebook or de novo referrals, then you kind of have to figure out how you're going to follow them better.
Yeah.
So if they don't have someone already doing their joint pain, then I'll say, okay, I'm going to see you in 6 months or something like that. But that's rare, more rare. Have you guys had any, this is educational, any complications related to GAE that you'd want to discuss?
I did have an issue once with the TCBNK, caused spasm. I saw a definite change, angiographically that gave me that pucker kind of a moment, but it was fine. I did nitro. There was nothing secondary that luckily that had to be done. And then I'm trying to remember if this is a GAE case or not. I think it was I think Faraz, you might have been there. I don't remember now, but I think it was a GAE case where it was a closure device, type of a scenario where I thought I might have had some distal embolization, but then I went through the foot to do an angiogram and everything looked fine. So I don't know. Whatever it was transient resolved. I've never had, we get the rash. I don't do the ice packs unless in the study they want us to do that. But the rash, I haven't had any skin breakdown, toe ulcers. In our clinicals, one of our earlier studies, there were 2 people who ended up with transient leg numbness that resolved. And that's when we upgraded our particle size from 75 to 100.
Yeah. Okay. I thought I'd heard about that. Yeah. So nothing permanent.
Thankfully,
Some
no.
temporary stuff.
Thankfully,
Same
no.
for
And
us.
moving that thing to the pedal, I was worried about that, but still, thankfully, no.
Yeah, knock on wood, not much quite yet, but when I was using particles, similar in terms of just, having the rash for a little bit, or just have the, patients having a little bit more pain and discomfort in the post-operative setting as compared to a resorbable agent. But I haven't really had much of that issue once I kind of switched to using mepenum. They don't really have much of that rash at all. I've never really seen a patient with that. I did use ice packs when I was using particles as well. I don't know if it particularly helped, but I subjectively maybe thought that the rash wasn't as bad. So I did use them. And we'll still use them for the research studies as well.
I have actually two more things I wanted to mention about that. Back in the study situation, there was I think a patient ended up, had a bone infarct. It was a long time ago. It was prolonged pain, and I don't know if it was a bone infarct or it might have just been an abnormal MRI signal edema. And then recently I had a patient who had worsening pain, severe pain afterwards. And it was already like 6 weeks out. And so I was really worried that maybe something was going on with like an infarct or something. I had used imipenem too. So I was like, this is so strange. So I had her get an MRI. The MRI didn't have anything really to show. And when I followed up with her, she's like, it's better. So I don't know what that was all about. But she did have prolonged worsening pain for a while.
So like 6 weeks of worsened pain post-op. Sounds like, okay. But then it resolved. I think I've seen a couple cases over the years on my end that maybe at like the 1 month, they had worse pain than they had before I treated them. But then when we followed up at 3, their WOMAC was down. And so we called it a success, but like we don't know why they had increased pain. I haven't seen any skin breakdown cases either. Just, that temporary kind of modeling stuff.
Yeah, I think there was another one back in our original study, like a small scab, that just healed.
That's pretty small when you compare it with a joint replacement.
Yeah, right.
Non-healing incision, like all kinds of crazy stuff. Okay, any other stuff?
Just talking about, knee replacements and doing GAEs after a knee replacement. That's always a little technically challenging sometimes. How do you like to approach if you have a post-TKA patient, what do you like to do for yours, Rachel?
I just had one last Thursday that took 90 minutes. It's a lot of CR manipulation, I pushed it to the limit, like on a cranial caudal and oblique, and I was just trying so hard to get the origin of the inferior lateral. So it really, it's pretty much the same technique, but there's a lot more manipulating the C-arm. And sometimes
trying to see the origins of those vessels between the implants.
Sometimes you get lucky, right? You can't see the origin and you get lucky. But I think, what about you? I know Ivy probably has a lot of that. And you probably treat a lot more than I do of these knees. What do you do different?
No, very similar. I think it's a lot of just manipulation and different angles, either, cranial caudal, whatever possible. Sometimes I'll just really try to work with the prosthesis a little bit. Usually there's a little bit of a gap in between, so I could try to maybe use that as a little window if I'm able to line up my base catheter with that to see those inferiors. Those are the ones that tend to be most difficult with the knee replacements. I feel like if you're lucky, you can get the superiors pretty well in the DGA.
Yeah, usually,
but the inferiors tend to be a little tough.
Can be hard. And so, another thing I'll try to do if I really can't get the prosthesis off where I'm suspected is if I'm using the Hastings U, I'll just do a push-up run. You know what I mean? So that when I see it, I'm like, okay, maybe if I just futz around over here, I can get lucky, but with variable success. And I find those patients, I have a small N of those patients, I admittedly. So I probably haven't really done more than, I don't know, 30 at most, maybe. What I've seen is I don't think the success is as high, or it takes longer than it would with, a native knee. I don't know if you guys have a similar experience with that, or maybe it's because my N is so small. I'm not, because I'm not getting as many arteries.
I definitely found those more challenging.
Yeah. For the most part, I think Ivy definitely has a lot. She sees a lot of post-TKA hemarthrosis patients, so she'll use beads for those patients a lot of times, but it does significantly help with the hemarthrosis component, and then they do have some pain relief as well. But primary pain after TKA, I've had kind of mixed results as well, I'd say.
And luckily, it's my understanding that it is more like pathology usually comes from the superiors in those situations. So it's lucky for us that those are usually easier to see.
Yes.
So that's post-TKA pain and the challenge of that too. Any other thoughts on GAE?
I think more to come. I think there's a lot down the pipeline in terms of GAE itself, type of embolic to use, how much, what's your endpoint. So there's a lot of variability, I would say, between person to person and a lot of the papers out there in terms of how many arteries they're treating, what's the appropriate number to treat. So I think we have to work on that a little bit and get more published out there to help ourselves out.
Yeah, and long-term data.
Yes.
Longer than 2 years. It'd be great to have longer term data out there. And we've got those, I think, is it 2 sham studies out there now that we've all been looking at?
There was that one recent one that was sad results. The journal club.
Well, I'm sure they'll have a response study coming out to that. Great chatting with you guys about GAE. Thank you, Rachel. Thank you, Faraz.
Thank you for inviting us.
Yeah, thanks, Don.
You're very welcome. Thank you for joining me. And just so the listeners know, both of these folks have done a whole lot of GAE. I think we touched on it in the beginning, but these are folks who are very experienced in GAE and embolization in general. Well, I think we can wrap it up. Thank you, guys.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza, Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.